And these are great presentations coming up. The one on August 5th by Dr. Azar, he gave something similar a couple years ago, and it's resonated with me so much. So I'm really excited to have him coming back to give us that presentation. So save the date for August 5th. I am extremely excited to introduce Donna McCurry for her presentation today on vascular access and sickle cell. Donna is a board-certified family nurse practitioner. She received both her bachelor and master's in nursing at University of Kansas. She started her nursing career in 1980 as a field nurse with the Wyandotte, County Visiting Nurse Association. And since 2008, she's been providing specialty care to adults living with sickle cell at University Health, which serves as the primary teaching hospital for the University of Missouri, Kansas City. She's also the recipient of several nursing and business awards, and she's the site PI for the Heartland Southwest Sickle Cell Network and Granddad Research Study. So with that, I would love to turn it over to Donna. You should be able to share your screen so you can start your presentation. And Gay's presentation sounds wonderful as well. I'm so sorry, I didn't mean to come off and only talk about one of the upcoming events. We have really lovely presentations and didactics lined up over the next few months.
Sonia, there we go. All right, I'm gonna let Sonia advance my slides. So our talk today is on vascular access devices in sickle cell. And the subtitle to that is What's in a Name? We can go to the next slide. So I have no disclosures. So I'm starting a background to kind of preface how this topic came up. And I'm just going to share a conversation that Ashley and I had after the December echo. And unfortunately, these questions came up after the echo, but I went ahead and emailed her. And this is the gist of our conversation. But I asked, I don't even remember what the December echo was about, but some kind of way apheresis and ports came up. And I asked Ashley if she could clarify her described use of the barred power apheresis being only for RBC exchanges, because my site uses it for other stuff as well. So and then I'm asking about terminology, and I asked her what's the name of the dual chamber port that's shaped like a Mickey Mouse ears. And then I shared some of the use of the barred power apheresis per our local community blood center apheresis nurses, and some of my uncertainty as to what our older ports are named. I'm asking, are they, maybe they're barred power ports or vortex, and what's even a vortex? And there seemed to be a lot of used terms generically that I wasn't sure if they were brand, you know, or nicknames, or just what are we calling ports? So I had a surgeon that even referenced that she was going to do a vortex port for us, but instead I won't say instead, what got in place was two barred power apheresis ports. So again, another example of what's in a name. And did she really want to do a vortex, or did she really want to do the barred power apheresis ports? So I see a lot of reference to vortex, but on checking in our records, they may have something else actually placed. So is vortex being used misappropriately? And same for portacath. Isn't this a brand name for a port? So all these questions regarding terminology, what are we calling ports? And we went on and exchanged some of the our approaches and how we selected the product specifications. So we go to the next slide here. Sonia, can you advance me? Okay, there it is. I'm going to kind of summarize some of this, but in asking Ashley what kind of ports they were using, she shared that the angiodynamic dual lumen 12 French port with the vortex capability is what she thought was generally used across the country. So there's that name vortex that's coming up again. Then Ashley also shares the anecdotal evidence that the barred power flow, which I wasn't quite sure what that port was, seemed to be less well received by her apheresis friends. She shared there's no head-to-head studies. And so through all of these email exchanges, that led to Ashley suggesting that I do this talk. So good or bad, I'm going to share with you, if we can go to the next slide, please. I'm going to share with you some of what I found. And again, I keep getting stuck with what's in a name. So I started asking various colleagues about what they call their ports. BARD frequently came up, the angiodynamic came up. Some people just called it a port. I have a colleague, he swears by calling the BARD power flow IV apheresis port, the titanium one. And I'll address that later as to how I've been able to work with using like terminology, but also correct terminology. And then he tells me, he says, well, when I redirect him to use the correct name for that BARD power flow IV apheresis port, he says, well, why does it matter? And it's too much to say. And so he's correct in one sense, but incorrect in the other, in that it does matter. So, okay, that's good. Here's an example. What's in a name? You know, Kleenex is a brand. It's considered to be a tissue, but a lot of people, when they ask for a tissue, they'll ask for a Kleenex. And then there's Portacath. Come to find out, Portacath is actually a brand of a port, but we use it rather generically. So what I'm hoping to get out of this talk today is to have a better understanding of what the different ports used in sickle cell care are, and their correct product names versus just acquired nicknames or misappropriation of a brand name. And then also to review a case of port misidentification and implications as it relates to patient and provider education. So after this talk, I'm hoping you'll be able to refer to a table to compare and contrast various ports by maker, model, and application, correctly state the name of the only FDA-approved port for apheresis, and review individual practices for performance improvement relative to staff and patient port education. So I'm going to stop for a minute and say I've had tremendous tech problems over the last 2.5 weeks or so. I had to do another presentation 2 weeks ago, and my computer crashed, and I sent the computer out and got it refixed and got that presentation done, then started on this one, and it crashed again to the extent I couldn't recover my work. So I started over from scratch last night, and trying to make it look pretty like Maya's port, like presentations do. It crashed again at 3 a.m. in the morning. So I'm panicking because I don't think I can do it just off the top of my head. So I did not get a chance to include the comparison chart. I did get the computer going back. I don't know what this presentation looks like because I was in the process of proofreading and dressing it up when it crashed. So I really don't know what this is going to look like. But I do know I did not get the comparison table in there, but I will forward it to Sonia so she can distribute it, and I will reference it. It's on the reading list. So with that said, the main thing I'd really want people to come away with today is really embracing understanding what's in a name. And if you don't remember anything else from this talk, you know, to know that the one and only FDA-approved port for apheresis is called the BARD Power Flow IV apheresis port, which is a mouthful. And I'm seeing different abbreviations, and some of them are still confusing to me when it gets truncated. So let's move forward and take a look at what I've come up with. So I'm using this as kind of a case to describe, you know, the different ports and what can happen when the name is not used clearly. And I'm going to use this case, and it'll kind of evolve throughout the presentation. But it centers around a 33-year-old male who has hemoglobin SS. He is on hydroxyurea. And he had a more, I don't know how to say this word, but it's where you get that shadow, that curtain vision over one eye. That happened in October of 2022 after a cluster pain crisis. And his symptoms were concerning for a TIA or CVA, and I've got here that he's got beta zero thal. I really don't know which one it is, but they're all treated the same. So in consultation with my hematologist, we decided to put him on exchange transfusion. So we got him set up with surgery and scheduled for a dual chamber port. So what some of the decision making that I didn't have then that I would probably take and consider now involves looking at what's out there in terms of dual chamber ports. So we have the Bard Power Port Duo MRI versus the angiodynamics for Vortex LP Dual Lumen, which, you know, we hear both of those words a lot: Bard ports, angiodynamics. But what specifically are those? So Lewicki and colleagues actually looked at the manufacturing and functional differences of these two ports. And the Bard port, it has a polyurethane catheter. Compared to the Vortex port, it has a silicone catheter. So Lewicki and his colleagues thought with the thicker catheter walls and the narrow lumen of the Vortex would affect its performance in relationship to the Bard port. And so their question they asked is the Bard flow rate superior to the Vortex simply by the nature of the difference in the catheter makeup? So they had 9 patients ages 16 through 40, and they looked at a total of 125 red cell exchanges. Interventional radiology placed all of the ports in the right anterior chest, and it was tunneled into the internal jugular. So the breakdown of the ports were 5 Vortex and then 4 of the Bard Power Port Duo. That's the PPD. So some of the results included that one of the patients had a thrombus, and that was with the Vortex port. None of the ports were removed and none of them had infections. They found that both were effective with adequate flow rates, although the Vortex port was unexpectedly faster. And that's the one they thought would be slower because of its the composition and the size of the catheter. But there were no other complications. So essentially they thought they were kind of equal. The Bard PowerPoint Duo and the angiodynamics Vortex, they were kind of equal. They did decide that future studies should include looking at the new port, which is the only FDA approved one for apheresis, and that's the Bard Power Flow IV apheresis port. I'm saying it over and over again so that we get that. And then to also look at over a longer period of time. So go to the next slide. So these are again the 2 ports and kind of what they look like. You know, you see the double barrel, and you know, to look at them, they look similar. Again, the composition of the catheter is different. So let's go back to our case and see what happens. So the decision-making with this individual's port kind of was more anecdotal. It really wasn't based on what I'm doing now in terms of a literature review or checking with other providers. So we had used the Bard Power Flow IV apheresis port in one other individual prior to making a decision regarding our cases port. And it resulted in an infection within just a few days of being implanted. And in retrospect, the site was difficult and the patient had a lot of psychosocial variables. So she probably maybe even wasn't a good candidate. But these ports that were put in her right thigh, because 2 of them, because her chest, all the available vasculature in her chest had been used up with previous ports. She had a stroke when she was like age 5, and at this time she's now 30, so she's had years of different ports being put in, put out. She had nothing available in her chest. They looked in her arms even, so nothing was available. So this thigh was the only place that was available, and it turned out to be horrible. So with that in mind, I said, well, I don't know if I want to use this Power Flow IV apheresis port. Although I was still hearing good things from our transfusionists from the community blood center. They were still saying how well it flows. They get less interruptions. If need be, they can access those ports. but they can't access the other standard ports. So anyway, we decided to go with our standard dual chamber port, and I put standard in parentheses because we really don't know what our standard is. We're having ports put in without really knowing the name. Again, getting back to what's in a name. So we send an order over to surgery, and we say, put a port in for us, dual chamber or single, that's the specificity. That's the only specificity that we ask for, be it a dual or a single. So with him, we wanted a dual so that we could do the red cell exchange. And that was 2023. So in the surgeon notes, hold on just a second, let me go back, sorry. In the surgeon notes, he referenced Vortex, which I now know to be the angiodynamic brand. And then I really wasn't sure, but I trusted the surgeon, I trusted the department. They put in thousands of ports, they know what they're talking about. I'm just gonna go for it. However, we unexpectedly end up with this person getting 2 of the barred power flow IV apheresis ports. Now we can go to the next slide. So caution, ding, 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 ding. Again, what's in the name? What got lost in translation? And we still haven't really figured out what went wrong. And I think at this point, with having a little bit better understanding of how to even ask the right questions, we're going to go back and do a deeper analysis of what happened with that communication from we want a dual chamber port and ended up getting 2 of the power flow ports. So we're going to be investigating that, and maybe I can come back and report on that later. So I think part of the problem was name similarity. BARDS has a family of ports, and their barred power port, which is your standard or traditional port, has a similar name to their new port, which is the barred power flow. So you have barred power port, barred power flow. They sound kind of alike. They might be the same thing. And that's coming from a perspective of people who may not really know the difference. So again, something we're going to look at is, I'm not quite sure how this fits in here. One of the things we need to make sure of in training staff is identification by palpation, and not just going by what you think the port is. Verifying the port by looking at the ID card, which sometimes our patients don't have. And then also recognizing that we think we need a lot more additional specific training on all the ports, not necessarily just the one that our institution might prefer to use. Let's see, how's my time, Maya?
I'm muted. You're good. You still have like 7 minutes left.
7 minutes. Okay, so let me hustle up. Here's a picture. Again, this is what I'm talking about. You see the names there: power flow, power port, but they're 2 different ports. The one on the left it came out in 2017, and it's the only FDA approved port for apheresis. We use the other port, the power port, for apheresis, but again, the power flow, because of its dynamics and how it's, there's a lot of specific biomedical stuff that I'm not even going to try and explain, but we need to be careful not to be confused with these 2 ports by looking really hard at the name and understanding that these are really 2 different ports, the power flow versus the power port. I went and asked my nurse, one of the nurses that's been she's been letting me use her as a sounding board as I find the information. And when I saw this power flow, this reference to the power flow being the apheresis port the other day, I asked her, I said, what do you think a power flow is? And she says, well, it sounds like just a power port. So again, I think BARD did us an injustice by naming these 2 ports so closely alike. Let's see, I'm going to probably I'm not going to go through the details of this, but Duke Adult Bone Marrow Clinic did looked at the BARD power flow IV apheresis port, And they basically concluded, this was a nurse-driven study, as and they were impressed basically with how that port functioned, and the nursing staff is going to continue to advocate for continued use of the Bard Power Flow IV apheresis port. So we can go to the next slide. I'm gonna skip over this one. Let me see. Let me just say this. This was a study done again of the Bard Power IV apheresis port at a Mayo clinic down in Phoenix, Arizona. And their conclusion was that the Bard Power Flow is a practical alternative to traditional vascular access devices. Actually, it's chimed in down there. We'll look at that later. So let's move on to our case. So our case patient moved out of our service area. So we did a lot of planning and a lot of care coordination. Our whole team did, with working with his new team that's in another location almost 200 miles away. We talked with the existing lead apheresis nurse, who has some familiarity with the Bard Power Flow port. And he agreed to take on the case, to be prepared, to take on our case. But then he retired before he could even do the first exchange. So there was a new person that stepped in. She had no experience with the Power Flow IV apheresis port. So we did a lot of training with her and hooked it up with resources. We did a live video with her, and we thought that she had it, but with the first exchange, she accessed the port as if it was the traditional non-coring port, where you go in with the 90-degree angle with a non-coring needle. We were so afraid the port had been destroyed. But she set him up to send him to interventional radiology because she thought the port wasn't working. And we finally brought the patient back up to Kansas City, to do the exchange. We talked again with the provider down there and the nurse, and I think we got them on board. We did get them on board with the proper way of recognizing that this was not your Bard port. It was a Bard Power Flow. Let's move on. So again, there they are side by side. They feel different. They totally feel different, under the skin. So that's the first thing we're trying to emphasize: check and feel, which I thought that was should be standard procedure. Next slide. Here's a picture of the vortex angiodynamics, and again, the different angle, the straight up and down angle that's used. And next slide. So here's some anecdotals in terms of the Bard Power apheresis port. This is from our case patient. He says, first of all, ports are different, and the provider should always verify what port the patient has. Therefore, care might also vary depending on the port type, and he's right on point when he says that. Next one. And this one comes from our sickle cell, the nurse here in my clinic. She has found them very easy to access, and it's easy to learn how to use them. You can skip the autoplay step. She does share that there is a difference in the cost of the needles, and I can't remember if they're more or less, but she basically likes them. Next one. And then back to our case. He ended up having an actual CVA in March. He got his first exchange done with his new ports at a hospital that fortunately had just adopted the Power IV apheresis ports. There's another story in here, and I'll say that for another day. But he was lucky he ended up being in a hospital that was familiar with his ports. Next one. Let's see if I can kind of wrap this up. Oh, I got to share this one. So this is from a physician at the same hospital that our case went to. And this is what he says about the Power Flow apheresis ports. He's been very happy with them. He uses them routinely in his clinic. He likes the acute access angle that results in less turbulent flow, the no silicone dome to puncture and potentially fail. He's very mechanical in his description. There's a trap door that the needle pushes aside and returns when the catheter is removed. They're rated for thousands of procedures, and he wouldn't do long-term patients without them. So that's become their preferred port, the Power Flow. IV apheresis port. We'll move on. I think I'm going to skip this. Well, let me just say this. This patient has a port. She also has chronic pain, and has had a lot of day hospital, and she's expecting her power apheresis port to be accessed when she's in pain for pain medicines, and we tend not to do that. But she gets upset because if you can't use this to give me my pain medicine, what good is the port? And she's forgetting it's being used to prevent her from having another stroke. I'm going to kind of I'm going to go through that because I already talked about this. This was some of Ashley's comments on the port. So let's skip that. And one last check-in on our case. So one of the ports was not drawing blood. This was just a couple of weeks ago. And at the institution he's at, autoclaves is not allowed to be used by the registered nurses. So she contacted the provider, and he was going to send him for, the patient says surgery, but I suspect he probably meant interventional radiology to clear the catheter. He says, I'm not going to do that. I have too many medical bills as it is. I can't remember if we've discussed bringing them back up here, but I'm going to offer to him to come back up here and let us look at the port. Let us try out the place before we do something more invasive. Again, some institutional variations that can impact care. And let's see if we can slide on to the end here. I don't know what's next. So again, what's in a name? Calling a port by its product name is not going to be detailed enough. My team here feel a little uncertain about just calling the BARD power flow simply that, because it sounds too much like the BARD power port. And I think until more people get familiar with this newer port, which is not that new anymore, it's 8 years old, we prefer to say the whole thing. And when we're challenging ourselves every day to say the whole thing for right now. Other things we need to look at is being more involved in the process from start to finish of when somebody is getting a port, making sure they have their ID cards. We did a quick survey. Our patients don't have ID cards anymore. We have like 16 patients or so on apheresis, and nobody has an ID card. I think some future study needs to be done on head-to-head comparisons of all the ports in terms of infection rate and thrombus and durability. So we'll move on. I think that's yes. So I went through that rather fast. Again, my main takeaway is know that the specific name of your port, and let's get away from tagging, giving them nicknames, or simply not knowing what they are and calling it Portacath or Vortex when it could actually be something else. Thank you for this opportunity. I hope it's been helpful for you.
Thank you, Donna. Honestly, this presentation is very timely because we recently just went through this entire ordeal with a patient and it's the only reason I know the difference between PowerPort, PowerFlow, Vortex, all of that is because of this instance where we had a patient who we were trying to get her set up for red cell exchanges. She decided, I don't want the exchanges, the port's too big. I rather just have a single lumen port so I have easy access. And we're like, okay, let's just do a single lumen so you're not feeling like a pill cushion. I've been at this university for over 10, 15 years now. For the first time in my entire life, took the liberty to place a power flow port because they're like, oh, well, you had put for red cell exchange. So let's do a single port that can do exchanges. And because of that, them taking the liberty to do a port like that without communicating with us, none of our nurses are trained to access a power flow port. Nobody will touch it. Only our phoresis department was arranged. And then now she's having issues and has to get it removed anyway. And it's so upsetting because we had delayed placing a port for all of these years and finally decide to do it. And now we really do need to start identifying by name because the power flow, I believe, is the only one that's capable of single lumen for actual phoresis. Otherwise, I see Donna Brewer also said the Vortex port is typically what we use as well for our red cell exchanges. Otherwise, I used to just call it a single lumen or a double lumen, not really realizing all the nuances from that standpoint.
Yeah.
Does anybody have any questions or comments for Donna for ports or vascular access?
I was just going to say we had like this is sort of what spurred this whole conversation, but like we had the same issue that Donna had where we had a power flow placed and the inpatient team accessed it like it was a regular port at that 90-degree, causing all kinds of issues to the port and the patient having to go back. So but our apheresis nurses, I think maybe similar to yours, Donna, like they really love the barred power flow, like it works better.
Mhm,
Like they don't need alteplase. So we've kind of
mhm,
settled with them, and we
mhm.
settled with SCDIR that we have both. So like
Yeah.
we are going patient by patient and making a decision on, okay, are we putting a power flow in, or are we putting the angiodynamics double
Mhm,
lumen vortex port in? And it's all like patient specific that we're making the decision on. But also like trying to have our apheresis nurses really try to do peripheral exchanges. So I know Sonia Wozniak at Hopkins has really pushed this forward with her nurses. And they've done a really great job there. It took like 5 or 6 years, but they're putting very few ports in.
mm.
So I think that's like, right, maybe the future here. Like I know our patients are such a difficult access, but if we could even avoid putting ports in them altogether, would be maybe just another layer to this.
Yeah, I think we forget the patient aspect of it sometimes, and the psychosocial impact and the body image, sort of things, and it's another layer of I don't know, coping skills, I guess that they developed that I think we probably underappreciate,
Right, you
and
have a
kind of,
constant visual reminder of having this and
mhm,
just the psychological impact of that as
yeah.
well. Cool. Well, I mean, this was like a research project on a small scale where you started with a question and kind of went down a huge wormhole. And I kind of love how this presentation came to being. So thank you so much, Donna. And if you have anything to share with the group, just forward to Sonia and she'll disseminate it to us. And I agree that we need to start calling the ports by their names, not just single lumen, double lumen, things of that nature to prevent the confusion. So now I'm going to turn it over to Ashley, who's going to be presenting a case. Ashley, I don't know if you want me to share my screen. Sonia, I don't know if you have it up, whatever's easiest.
Yes, I'm pulling it out. I'm pulling it up now.
Awesome.
Thank you, Sonia.
You're welcome.
All right, perfect. So this is my patient who's a 47-year-old with hemoglobin S beta plus thal, who actually presented to the emergency room yesterday with new onset of ringing in his ears and hearing loss that had been ongoing for the past week. Had not had any previous admissions in the last 30 days, but did have 2 ED visits just in the last year. He does not really come in all that often for acute care utilization, and has very few vaso-occlusive events. He's on a med surge floor. His hematologist is Dr. Risk. His primary care provider is Rachel Rosali. Has some pain to his shoulder, which is kind of intermittently chronic. He doesn't have it every day, but he does have AVN there. Is not on a long-acting opioid, is on oxycodone 5 milligrams, but really is just prescribed 30 tablets a month. And sometimes that's every month and a half, 2 months. These are his home medications. And I guess the biggest one that I wanted to bring up was the prednisone. And so when he had this ringing in his ears and hearing loss, he went to ENT on Friday, and they started him on prednisone and a steroid taper, starting at 60 milligrams for a 14-day supply, as well as he's on Norvasc, lisinopril, Lasix, vitamin B12, allopurinol, and on hydroxyurea, which he's been on for several years. He's actually not on any IV opioids, is not having any acute pain at the moment, although sounds like over the weekend did have some increased pain to that shoulder, but that's resolved. Is currently on a bowel regimen while he's here in the hospital. Does not have a history of acute chest stroke, does have a history of a DVT remotely in the past, and got a course of anticoagulation for 6 months and stopped. And no recent events. He doesn't have cardiomyopathy or pulmonary hypertension. He does have renal disease, does not have iron overload. And other notable history is that in addition to that shoulder AVN, he also has AVN of his hip and leg ulcers intermittently, although those seem to be better at the moment. He had an inguinal hernia repair in February of 2024. Does not have a history of depression, bipolar disorder, or substance use disorder, and no aberrant opioid use. Did, just looking back last year, one of those emergency room visits was not for pain. He actually had a panic attack episode in the setting of a recent COVID infection at that time, and then a dysphoric response to using medical cannabis that he had tried the week prior and then had not continued on it. Is not in psychiatric care. Again, like I said, he's on hydroxyurea, 1,500 milligrams. This ANC was from presentation of when he came into the hospital, 5.52, and he's been on hydroxyurea for several years. Not on chronic transfusion therapy, does not have alloimmunization, does have an active sample in the blood bank, and he did get an exchange prior to that inguinal hernia repair in February of 2024. You can see his vital signs are here. They are stable. He's 98% on room air. His baseline hemoglobin is 10 to 11. His hemoglobin on presentation yesterday was 10.4 and a hematocrit of 27.9 with a white count of 6.1, neutrophil count of 5.52, MCV of 104, platelets of 655 with a retic count of 2.1 and absolute retic of 55.4. And his hemoglobin electrophoresis, this was from like several years ago. We had gotten one when he had come in, but his hemoglobin S was 71.3 and hemoglobin A 18.1, consistent with his sickle beta plus thal. His creatinine is 1.8, which is a smidge higher than what his baseline is. It's usually around 1.4. And his total Billy is 0.5. And then he had a urine toxicology that was positive around sort of that time of that sort of the dysphoric response to cannabis that was positive for cannabis back at that time. We had ordered an MRI and MRA when he had come in yesterday, and it looks like he got that done this morning. I just recently checked, but it hasn't resulted at the moment. And he has Aetna Medicare insurance. And so like the biggest questions here for me were, right, this is a guy with sickle beta plus thalassemia with new onset hearing loss and tinnitus who was started on steroids by ENT. And so like, again, like what additional workup we felt like it was necessary to get an MRI, MRA of his brain. He hadn't had one to rule out any CNS cause of this new onset hearing loss. And then how sort of to best protect and optimize him from a sickle cell disease standpoint. And if his MRI, MRA came back negative, would that change your management?
Awesome. So just to summarize, this is a 47-year-old man with sickle beta thalassemia plus. He presented to the ER with new onset of hearing loss and ringing and started on prednisone by ENT, history of avascular necrosis, leg ulcers, DVT, kidney disease. So his creatinine of 1.8. So obviously from a sickle cell standpoint, that's a little concerning, although I know that is not the reason for presenting this case. I have some questions, but I'll open the floor up to others first to see if anybody has any clarifying questions or comments regarding this case.
Ashley, is he just on hydroxyurea? I kind of got lost.
Yep, just on hydroxyurea.
Does he have frequent pain crises?
He doesn't. No, like 1 or 2 ER visits a year.
I was thinking Indari, but if he's not having, sorry, I'll get on video. If he's not having pain crisis, I don't know that I would use Indari. I'm just trying to think of something else you could add to his hydroxyurea regimen.
Looking at his medications, he does appear to be on some blood pressure medicine. I see that he's on lisinopril and Norvasc, and sometimes those, I wonder, when ENT saw him, did they do specific testing to try and determine the mechanism of hearing loss, or is it more of a subjective tinnitus and
No, they
hearing?
did do formal audiology testing, and now I'm getting my sides mixed up, but they did see unilateral hearing loss, which is what prompted them to put him on the steroids.
Okay, because I'd be interested in their testing and then see, do they think it's medication related, just knowing that some of these blood pressure meds can cause autotoxicity. Rarely, we know sickle cell can affect the nerves, and that can be reported as well. Any recent infections or situational, like anything new over the past week or the past few days leading up to this ER visit?
No.
Yeah, thank God for specialists, right? No kidding. But I think the MRI MRA is going to be very revealing. Hopefully it is, and give some insight. Otherwise, I wonder if it's medication related or is it related to just sickle cell? If they did testing, I assume they wouldn't have started on or actually, I'm not going to assume because we know what happens when you assume. But I would want to just get in touch with ENT because this is where we know a lot, but this is where leaning on the specialist for hearing loss specifically and see, do we think this is related to the disease process? Do we think it's medication related? And just get a plan in place for if there's no improvement, like what are the next steps? That way the patient can kind of advocate for himself too and know what normal and abnormal. And then for me, anytime I have patients complaining of ringing or hearing things, I usually will just kind of treat like Meniere's and just recommend a low sodium diet and an increased fluid intake and just see from a lifestyle standpoint, is any of that helpful? That's hard because
Yeah.
he's on
And
this.
then, no, I know. And so we actually ended up, because we put him on, he needed to go on steroids, and their hope was like, if we put him on a high dose steroid, this will resolve and there won't be any permanent hearing loss. And so in the past, when I've had patients like this, right, if they've had SS, it makes it a little bit easier, right? Like I've just simply transfused them to give them the protection against the high dose steroids.
Right.
Even with him having sickle beta plus tau, we ended up just deciding to exchange him. So he's actually being exchanged this morning, just to kind of protect him from the steroid while we get the information as it relates to like the MRI to make sure that there isn't, you know, a stroke, which I think would, that piece, right, would
Right.
likely change our management of how we would manage him from a sickle cell disease standpoint. But if it's negative, you know, I've had patients like this before where I haven't committed them if they've had one event to chronic exchange transfusions. If there is no like CNS vasculopathy or CNS involvement, but I think like the literature there is a little bit, right? Like I don't know what other people's experience is like. And I think, right, I saw one article about hearing loss in people with sickle cell disease. And I think relatively speaking, we don't really understand the mechanism
Right.
there. And because I've had a handful of these patients now that I've seen, I'm like even more in tune to like ask that question to my patients, because I have seen a lot of older adults that have been like, oh, I just have had this hearing loss now for like several months. And our ENT colleagues are like, no, like once they have it, send them to us, because sometimes either oral steroids or the interauricular steroids can help prevent this from being a permanent damage for the patient. So I'll let you know. When I talked to him yesterday, really the steroids hadn't helped a whole lot. Like he was still having pretty significant hearing loss, like subjectively, and the ringing in his ears, but we'll see.
And I would also just ask them about his blood pressure medicines, just since all of them
It's a good point.
independently, even though rarely it can cause, I just remember on my board exam, Lasix and autotoxicity. There were a few, the PTSD from my board exams. But I would just confirm there's not a medication effect, because even if you can hold it and do an alternative, but check that. And I'm glad that you at least exchanged him. So worst case scenario has been addressed. And hopefully there's some improvement. I think it's hard because he's 47, so there could be some age-related decline in hearing, but obviously with sickle cell, it could be anything that we want to rule out the worst case scenario. So keep us posted. Hopefully we'll get some information from the MRI and MRA. Any other questions, comments, feedback for either this case or for the vascular access? The exchange is actually just given his kidney function too. If there was, or just depending on the MRI, MRA results. For those, I don't know who all is on the call, but as a reminder, creatinine is not a reliable indicator for kidney function for our patients with sickle cell, because usually, just since there's reduced concentration of urine, a creatinine is usually going to be low. So if we're going to wait for a creatinine to be elevated to diagnose with kidney disease, they're going to be very advanced. That's why we do the urine protein. So him being at 1.8 and starting on exchanges, I mean, maybe that offers some level of protection from a kidney function standpoint too.
No, but I think it's a good point too. Like I wasn't even the Lasix is such a good point in his lisinopril. Like, you know, even though his baseline creatinine of 1.3 is like not normal. And so I think engaging the nephrologist here to think about like alternatives, especially if he continues to have this if he continues to have the tinnitus, right? Like, is there something that we can do to continue to protect his kidneys? But also like if we think that this is causing any of the hearing impairment.
And then just lifestyle standpoints, tinnitus can lead to a lot of depression and whatnot. If you think just having that constant nagging, and sometimes just from like a sleep hygiene standpoint, you can recommend a white noise machine, things of that nature to help prevent it from interrupting with sleep as well. Awesome. Cool. Well, that was a nice case. Thank you, Ashley, for always pulling in at the end. Again, if anybody is ever interested in presenting either a case or a didactic, I think this is a really nice opportunity, and we're just very warm and friendly, and really it's a non-threatening environment. So I think anybody who is just introduced to or wanting to start their presentation from a professional development standpoint, just know that's always an option. Just reach out to Ashley, Sonia, or myself. And if you have any complex cases that you want to present and just get other feedback, you can reach out. It can be medical, it could be psychosocial issues. We can cover it all. So any other questions? Otherwise, I can give you 10 minutes back to your day. Perfect. Well, thank you all so much. I hope everybody has a great rest of your week. Again, we have July 17th, we have the presentation by Gay Riddick. And then on August 5th, we have Charles Azar's presentation. And we're actually pretty far through the end of this year, early next year. But again, anybody who's interested, we're always looking for more presenters, more cases. And with that, I hope everybody has a lovely Tuesday, and we'll see you back next month.
Bye.
Bye. Take care.